Hello everyone, this is Kaustubh Kakade. I'm going to take surgery for you all. We are going to discuss and have a great time with the subject. Please follow us on Instagram at Inspiring Minds. And if you like the video, like it, share it, and do subscribe, and also comment for what you want me to do next. Yes, so let's start the video. So from today, we are going to start with the thyroid surgery, under which the most common presentation of a patient coming to a surgery department with thyroid complaints is going to be a thyroid nodule. Yes. So how do you identify a thyroid nodule? Yes, a thyroid nodule is going to be a swelling. It is going to be a swelling in front of the neck, in front of neck that moves with deglutition, right? Why it moves with deglutition? Because of the inferior constrictor of pharynx pulling it upwards when we try to ingest something. When we try to swallow, the patient is asked to swallow something, and during that process of deglutition, that thyroid swelling is going to move up and down. So that is a characteristic feature which helps you to identify it to be a swelling of thyroid. Because neck, it could be a lymph node, or it could be a cyst, or even it could be a malignancy, a secondary, anything between the swellings. But for thyroid nodule, a classic identification point is that the swelling is going to move in front of the neck, right, with deglutition. So now let us see what are the causes of thyroid nodule. Okay, this causes can be dependent upon if the patient is hypothyroid, if the patient is hyperthyroid, that is excessive amount of thyroid hormone T3 and T4 is released, or it could be a euthyroid patient where the thyroid function tests are absolutely normal. Even there are no complaints. Okay. So a hypothyroid patient could be coming with a thyroid swelling in conditions such as Hashimoto's thyroiditis, or it could be a benign mass. It could be a benign mass such as a follicular adenoma, right? Nextly, you have a hyperthyroid patient that will be coming to you with a thyroid nodule. It could be because of Graves' disease. It could be because of a malignancy, right? It could be malignant as well. Whereas a euthyroid patient is most likely to be a malignant one. One more interesting point to be added over here is going to be in the hyperthyroid patients, even toxic multinodular goiter is going to present to you with a hyperthyroid swelling, is going to present to you with hyperthyroid swelling, right? Now let's have a look as to how to approach a patient who is having a nodule, right? So firstly, I told you, you are going to look at a nodule. You got that it's a nodule that comes from a thyroid. So it is a thyroid nodule, right? You have identified it to be a thyroid nodule, right? Now, the most important step to identify, irrespective of the symptoms of the patient, is whether the patient is euthyroid, hypothyroid, or hyperthyroid, especially when it is suspicious. When it is suspicious clinically. Okay. The first test that you have to do is going to be a thyroid function test, under which it is very, very important for you to identify a level of TSH. Yes, so you need to know what are the TSH levels in this case. Now, Once you get the levels of TSH, there are two possibilities. Okay, there are going to be two possibilities. The one possibility that you have is that the patient is hyperthyroid. That is, the TSH levels are going to be low. Yes, the second possibility is going to be a patient is hypothyroid, and the third possibility is a patient is euthyroid. Hypothyroid means euthyroid means TSH is normal, and hypothyroid means TSH is high. Yes, now just tell me, if a patient is having a suspicious nodule and he is hypothyroid or euthyroid, that means the levels are low or the patient's TSH levels are high, he is within normal range but coming with a nodule, the suspicion will increase. Definitely the suspicion is going to increase. So that's why, to rule out any form of extravagant lesions, the next step for both of these cases is going to be strictly go for a fine needle aspiration cytology. That is, you are going to do a FNAC, right? It's that clear. Now, if the patient is having hyperthyroidism, you need to understand how active is the thyroid gland to rule out possibility of medical disorders and a surgically important disorder. If the patient is found biochemically hyperthyroid, you need to know the activity. How will you know the activity? A simple step to know the activity is going to be a radioiodine scan. You are going to do a radioiodine scan. So it's that simple, that if a patient has a thyroid nodule which is clinically suspicious, first you will check the TSH levels, then you are going to check the hyperthyroid, hypothyroid or euthyroid states based on the TSH values. If it is low, that is hyperthyroid, go for a radioiodine scan. If it is hypothyroid or euthyroid, that is TSH is high or normal, directly go for FNSC, because there is high suspicion. There is high suspicion, right? Now, let's see what you get from a radioiodine scan. Yes. Now understand, if a nodule is highly active, if the nodule is highly active, it will take the dye. But if it is not active or low active, it will not take the dye. It's that simple, that you can understand from this image. Now just pay attention over here. This is a nodule which you are clinically suspecting. Clinically, you will identify which part of the thyroid the nodule is in, and that has to be studied in comparison to the normal other parenchyma of the thyroid. Like this, here, suppose there was a right upper lobe nodule. In this case, you can see there is a right upper lobule, and here in the nodule, what you have is, this is going to be a nodule. Here, if you check the iodine scan, then what you get, that the other parts of the thyroid are taking the dye, but the nodule itself is not taking the dye. This is called as a cold nodule. This is called a cold nodule. Now tell me, if a nodule is cold, it is not taking dye, but still the patient is hyperthyroid. That means again some malfunctioning is taking place. So now I can say that if the patient on the radioiodine scan, I can have a cold nodule or a hot nodule. Simply. Okay. If I am having a cold nodule, this is going to be a high suspicion, because in spite of having a low activity, why the patient is hyperthyroid, there is some malfunctioning definitely going on. So in that case, what you are going to do? You are going to do a FNAC to again rule out that suspicion. Yes, you are going to do a FNSC, fine needle aspiration cytology, to rule out that suspicion. But see, in the second image down here, you can see that the remaining thyroid is not taking up dye, but the suspected nodule is taking up dye. Why? Because that suspected nodule is so active that it is not letting the remaining thyroid to take up the dye. That means a nodule which is very, very active and the patient is hyperthyroid. So this is a simple medical condition, uncomplicated. And what will be the diagnosis in this case? The diagnosis in this case will strictly go towards, will simply go towards a toxic nodule or a toxic adenoma, right? It will go to be a toxic nodule. And in that case, what you are going to do? You are first going to give a radioiodine therapy. You are going to do a radioiodine therapy, and this radioiodine therapy is going to be followed by a this radioiodine therapy. This good radioiodine therapy is to be followed by a surgery. Okay, this surgery will depend upon what lobe is involved in this, right? So that is all about here. What other variations you can get? Let's see that. So now what other variation you can get is, see, this lobe is diffusely enlarged, diffusely taking the dye, and the patient is hyperthyroid. What is this? This is Graves' disease. So how do you manage a patient of Graves' disease? Sorry, you manage a patient of Graves' disease simply medically by giving antithyroid drugs. Whereas a autonomous nodule means that the remaining gland is not taking the nodule, it is highly toxic, again comes under the category of very hot nodule, right? Whereas toxic multinodular goiter, some hot and some cold nodules. Yes, these are some cold nodules, these are some hot nodules. Here what you will do, here being a toxic, again give radioiodine therapy followed by a total thyroidectomy, whereas thyroiditis, everything is going to be etiological management, will be a etiological management. So overall, if you take a look in this video, what we have learned is, firstly, what to do when you have a neck swelling. You have to identify to be a swelling in front of neck, which is going to move with deglutition. Causes are going to be hypothyroid, could be Hashimoto thyroiditis, benign, hyperthyroid can be Graves' disease or malignant, euthyroid can be a toxic multinodular goiter, uh, or it could be a malignant one. Then a thyroid nodule, which is suspicious of malignancy clinically, go for TSH levels. This TSH levels will tell you whether it is hyper, hypo, or euthyroid. If it is hyperthyroid, for hyperthyroid, you will go for radioiodine scan to get the activity of thyroid gland. If it is cold, go for FNAC. If it is hot, you have to go for toxic nodule. If it is a toxic nodule, then you are going to go for a radioiodine therapy followed by a surgery. But if it is hypo or euthyroid, it is clinically suspicious. So the suspicion will increase in such a situation. So you go for FNAC to get a cytological report. That is how you are going to manage a case of a thyroid nodule. In the next video, we are going to continue with what happens in FNAC and how to diagnose certain conditions with FNAC, and if you get a FNAC report, what to do for that patient. Thank you for watching this video. If you like it, do like it, share and subscribe, and do follow us on Instagram at Inspiring Minds. Thank you so much.